Okay, let's get started because I want to be respectful of everybody's time. So thank you to our panelists and everyone who's joined us on the call for what should be a fantastic conversation. My name's Dr. Shuhan He, and I'm the chair and the co-founder of the COVID-19 Action Coalition, which is a physician-led advocacy group that has been advocating for evidence-based public health measures against the COVID-19 pandemic. And welcome to this town hall, which is the first in a series of 2 town halls on the related public health crises of COVID-19 and racism. And before we begin the meeting and introduce our panelists, I'd like everyone to know the format. We're going to have everybody muted except for the panelists and myself, who will be moderating the call. We'll have about 40 minutes of discussion, followed by 15 minutes of live questions. And if you have a question for consideration, please tweet it to @COVACMA, COVACMA, and that address should also be in the chat box. So I'd like to start off with brief introductions of our expert physicians who are joining us today to inform us on best practices going forward against the pandemic. And all 3 of these people are extremely accomplished physicians and scholars. So the introduction is only going to be a smattering of their accomplishments, but we really thank them for joining us. So Dr. Ashish Jha is the KT Lee Professor of Global Health at the Harvard T.H. Chan School of Public Health and the Director of the Harvard Global Health Institute. He's a practicing general internist, and he's also professor of medicine at Harvard Medical School. He is trained in internal medicine, and he will begin work as the Dean of the Brown University School of Public Health in September. Dr. Jha is probably a name that people on this call are very familiar with. He's been leading national analysis of key issues around the COVID-19 pandemic, advising policymakers and elected officials at the state and federal levels, and he appears frequently on national television news outlets. Dr. Shuhan He is an emergency medicine physician at MGH. He is the medical lead and co-founder of GetUsPPE. He also works as the associate director of the digital growth strategy at the Center for Innovation in Digital Healthcare at MGH. Again, as I'm sure most people on this call are familiar with, GetUsPPE is the largest national coalition of PPE donor database projects and has established a landmark centralized nationwide platform for PPE. And then our third panelist, Dr. Rajeev Venkayya, is trained in pulmonary and critical care medicine, and he is the president of the global vaccine business at Taekda, where he leads a vertically integrated business unit that is developing vaccines for dengue, norovirus, and Zika, and supplying pandemic influenza vaccine in Japan. He is an independent board member of the Coalition for Epidemic Preparedness Innovations, which is funding several vaccine development programs for SARS-CoV-2, and he previously was the special assistant to the president and senior director for Biodefense at the White House Homeland Security Council. He was the principal author of the National Strategy for Pandemic Influenza, and his office led the development of the companion implementation plan, and his team conceived the community mitigation guidance that is now known as flattening the curve. So I want to truly thank Drs. Jha, He, and Venkayya for taking the time to meet with us today. We'll begin by asking some prepared questions. And these questions were also informed by questions that people who are participating in the call today had a chance to submit. So hopefully it covers most of the key topics that everyone was super interested in hearing from our expert panelists about. So first off, we'll talk about the topic of reopening, which is on everybody's minds. We've had 3 months of stay-at-home recommendations, and now we're just recently launched into the second stage of reopening in Massachusetts. And there's a lot of debate in the community about how we can safely reopen the economy. There's also fear about the potential for rolling shutdowns, which damage the economy, which could damage the economy, education, and public trust. So, Dr. Jha, maybe we'll start with you. What do you think are the key considerations for safely reopening the economy at this stage?
So, thanks, Sue, for having me on, and thank you all for having all of us on for this, what I think will be a really fun conversation. So, yeah, so everybody is opening up, right? All 50 states and Massachusetts among them. In general, as I have looked at the Massachusetts plan, I think it is pretty well considered. It is all about going slow. And there are always trade-offs in terms of at what point do you begin to open up and what point do you start allowing more economic activity to happen. When I look at Massachusetts, we've had pretty consistently declining cases for several weeks now. So that's one of the classic criteria that the White House laid out, which I think is right. And we've done a pretty good job, though not as good of a job as I would like, on ramping up testing. I think we're not where we need to be on testing, and we can talk more about that. But overall, as I have looked at the Massachusetts plan and opening up, I feel like we're in reasonably good shape, but I would really want to continue tracking data very, very closely to see how things go before we go any further. This, by the way, just one last point on this, stands in, I think, sharp contrast to what we've seen in a lot of other states where states opened up before they saw declining cases, where their caseloads were much higher. And what we're seeing now nationally is probably 18 or 20 states where case numbers are really rising pretty substantially.
So how well do you think those recommendations align with the scientific evidence for this second stage? And do you have any concerns about what was just recently released in the recommendations for opening the second stage and in phase, the phase 1 and 2 of this, steps 1 and 2 of phase 2 of reopening?
So just being very honest, I haven't examined the individual phases as carefully. Overall, I know that there was a determination to get us into phase 2 starting this week. And what I guess I'm looking at this in the following way, right? Which is there are 3 factors. One is I'm watching the trends in the number of cases that are happening in the state over time. I'm looking at what's happening with testing, and then I'm watching sort of what's happening with how people are responding to this opening. It's very clear that the activity level in Massachusetts is starting to go up. And I think we're going to have to sort of see how things go over the next couple of weeks to really get a sense of whether we moved too fast or not. But there isn't anything specific that I'm seeing right now that concerns me about where Massachusetts is moving in terms of opening up. But obviously, I'll be curious what other people think about that.
Okay. Dr. Venkayya or Dr. He, did you want to offer your perspective on the reopening strategy in Massachusetts?
Well, I guess offer a comment. I agree with Ashish that this is a cautious approach to reopening that does reflect what we understand about the burden and transmission of the virus in the community right now. It's important to recognize that any low level of transmission of virus that we have in the community right now is the result of the quote unquote lockdown type measures. And so we have artificially driven transmission down as a successful result of very, very difficult, even extraordinary measures. And that's great news. But as we relax measures, we are effectively removing some of the layers that help to dampen transmission. And in the absence of replacing the layers that we remove with something additional, then there is the risk that the virus is just going to come back. We don't have a lot of evidence that the weather, the change in the climate, moving into the summer months here in the Northern Hemisphere is going to make a huge difference. One thing that we're doing differently that we weren't doing at the beginning of the lockdown uniformly is wearing masks, including in indoor spaces, including in places with poor air circulation. And so that would be an example of a layer that we are effectively adding to replace some of the restrictions that are being removed. And so that gives me hope that we will have if ever, a relatively slow rise that with appropriate testing will pick up.
Yeah, and I agree with all those points. You know, I think one of the things that I always put in context is that we've never done this before, right? And this is a very hard question. And no matter what we do, we're going to have more questions than answers, right? When I think about, especially from the PPE front, you know, all these factors are linked. So as she's mentioned, the infection rate, or what is the positive test rate as an indicator of how much we're testing, right? Still a little high in Massachusetts, probably around 10%. And does that mean we're just not testing enough, right? You know, do we have enough contact tracers? Do we have enough PPE? To be honest, we don't for a lot of these things, right? We don't have enough contact tracers yet, and we don't have a centralized understanding of how much PPE across the nation we need. At the same time, I do think our approach has been really cautious, and I think it's been to the best of our ability. And I think, you know, certainly with the demand across the country of needing to regenerate economic activity, right? It's not purely based on health. I think that also, you know, our recommendations make a lot of sense, certainly in context of this being a very, very difficult question to answer.
Okay. One thing that's been, thank you for those insights. One thing that's been on the minds of a lot of people is the fact that this COVID-19 pandemic, as well as reopening plans, tend to disproportionately impact communities of color and low-income communities. And so would you recommend any specific steps to make that reopening process equitable or to help mitigate the impact on those vulnerable communities?
So let me start off with just a couple of thoughts. One is that one of the things that I've been hearing a lot from people as I've been talking about this topic with folks is a lot of people are worried about folks who are, let's say, high risk, older people, people with chronic disease. Their businesses might be opening back up, and they don't feel totally comfortable about going back to work. And the fear is if they don't go back to work, they're going to lose their jobs, and they may not be eligible for unemployment. And a lot of the financial supports that we've been offering people are going to be going away as the economy opens up. And, you know, for people who are wealthier, who have more reserves, who can, you know, it may not be a big deal, but for a lot of people, that's not the case, and especially for lower income people, that's not the case. So essentially, those people feel like they're having to choose between their lives and their livelihoods. And that's a pretty tough choice to ask people to make. So I think finding some way of financially supporting people who don't feel comfortable going back to work, don't feel safe going back to work, is going to, I think, be a potentially really important thing. Specifically on the issue of thinking about communities of color, there is increasing evidence and data that, and I'm just going to pick on one very narrow thing, but I think it's very important. There's increasing evidence and data that testing has not been, the testing sites are not often in those neighborhoods, that they're often placed in wealthier neighborhoods, in wider neighborhoods. And so one of the many things that contributed to the substantial disproportionate impact that we saw, especially in the African-American community, was the fact that testing was not as available. So as we continue to ramp up testing, making sure that people have easy access, that you don't in neighborhoods put in drive-throughs in a neighborhood where very few people have cars. Just, you know, sounds really simple and silly, but there have been a lot of mistakes like that. We just got to do a good job to make sure there's equitable access to testing as just one key part of making the whole thing work better.
Yeah. Sorry. Just wanted to add to that I you know, one thing that I can't help to think about early in this pandemic was that, you know, when we work in a hospital, there was a story about how well prepared Mass General was because we had a really nice warehouse full of 6 months of PPE. And I couldn't help but think that every single time I'd see a patient from a nursing home, and then I'd see every other patient at a nursing home because it spread like wildfire throughout because they had no PPE, how useful it would have been to have that PPE from the warehouse to the nursing home. Now, obviously, this is a really tough question, right? Because healthcare workers needed PPE. But at the same time, we were already behind the 8 ball. And if we had a better allocation of that into other communities at that point, maybe it would have slowed the transmission. And thinking about, you know, how fast we burn PPE in the hospital, we burn something like 18 times more right, when we're in the hospital than when that same mask is we're in the community. I think, you know, just to go to Ashish's point of equitable testing centers, same thing for masks, right? We have, you know, so much more mask usage throughout the community. And I think making sure that communities that are really significantly underrepresented also have access to that PPE just on a day-to-day basis in their activities and their work is super important as well.
Did you want to comment on that, Rajeev, as well? Or?
Yeah, just very quickly, because
Yeah.
I want us to be able to get to more questions. I would just, first of all, I agree with everything that's been said. You know, any crisis like this is going to amplify existing disparities in health across ethnicities, across socioeconomic status. I think the targeted approaches that Ashish is talking about with regard to testing makes sense, as does ensuring that you have appropriate levels of health education in underserved populations. I would also say that the best thing we can do for communities of color is to reduce the overall risk in the community. And so that is a community-wide effort to continue to dampen transmission and keep transmission down.
Okay. I want to come back and dive in to PPE and testing in a bit more detail, but I think before we go there, something that's really on people's minds is reopening in the workplace and reopening schools and daycares. So let's start maybe with the workplace, Rajeev, and what does a safe workplace plan or strategy entail for small and large businesses? And then I think a related question is, what is the role of testing in PPE? And I'll get all of our panelists to comment on that. So, but I'll start with you.
Yeah, it's a huge question. We're in the process of issuing guidance to our 50,000 employees around the world, and it's quite it's complicated because you have to adapt it to the epidemiology in a community, as well as the way facilities are structured, as well as the way people do work. And the guidance that we're giving to manufacturing facilities is different from laboratories, is different from office environments, is different from the plasma collection sites that we have in the company. But I can tell you that we are looking at the employee journey from the moment they get in their car or on public transportation to when they enter their place of work, to the desk space itself, and then to the common areas where people interact with each other. And in each of those compartments, we are recommending steps to increase physical distancing and ensure a level of hygiene that limits potential virus transmission. We're also getting some, I think, appropriately helpful guidance from local authorities. In Cambridge, we have to keep the density in our offices at 25% of normal. So this means 3/4 of the people that would normally be in the office are not going to be in the office. On top of that, we're saying that if you can't physically distance from anyone, then in that environment, you need to be wearing a mask. And on top of that, based on emerging evidence around infection transmission in closed spaces, we're saying that if you're in an elevator, if you're in a stairwell, or any place where there is poor air circulation, you need to be wearing a mask. And if you're in that space, don't talk. These are the types of layered approaches that we need to take to make the workplace a safe place. But the reality is that the vast majority of our people that are working in office environments are not going to be coming back to the office anytime soon. And frankly, we are prepared to maintain this different way of working if necessary until a vaccine is widely available.
Danielle, if you could unmute our panelists, I think some of them might have gotten accidentally remuted. Thanks. Thanks for that. Ashish, did you want to comment on that also, the safe reopening plan for businesses, and what do you think the critical things are there?
I don't have much to add. I think we can keep going. I'm just going to quickly add that I think what Rajeev has laid out is what is sort of the level of specificity that companies need. And what just maybe one policy comment is, as you all might remember, the CDC actually initially came up with very detailed guidance, and then a lot of it got pulled back by the administration. And I think one of the challenges in this pandemic has been that we've been forcing companies to more or less figure this stuff out on their own. And there are companies like Rajeev's that can do it, but a lot of companies don't. And this is why we really need the CDC much more engaged on this kind of stuff than they've been able to, or they've been allowed to.
What about the role of testing and PPE in safe reopening of businesses? What is the role for testing and PPE?
Maybe I could start with this one, and let me
Please.
say that where we were a month ago on testing is different from today. We're better off today, and we'll be better off 3 to 6 months from now, I hope. One of the developments that we're seeing in this area is that there is increasing testing capacity that is being made available to the state of Massachusetts. And in our company, we are looking at the potential of using screening PCR in selected environments where a positive would have a high impact. And specifically, that would be in a manufacturing facility, where if you take out a unit operation because somebody is positive, then your entire facility could go down. So we're looking on a pilot basis at the value of doing PCR screening. I don't know if this is going to be effective and cost effective. When I say effective, I don't know if it's going to be incrementally effective over everything else that we're doing to keep virus out of the workplace. That's the purpose of this pilot. But I can imagine a day when the cost of testing goes down and the ease of testing goes up, such that you can do testing by sampling the anterior nares or even saliva-based testing, potentially even using an antigen assay like a pregnancy test that is inexpensive. This could potentially be a very useful tool. And the reason I think that there is going to be an interest in this is that until we have a vaccine, if you're going to an office environment like the one I just described, that's a pretty miserable environment. You know, it's not clear that you really even want to be in an environment that has 25% occupancy with, you know, no face-to-face meetings without everybody wearing masks and all the physical distancing that I explained. And so in that situation, there may be quite a push to have screening PCR or antigen testing to allow you to have more density. That's an if. I'm not saying that that's where we'll end up, but these are the questions that are being asked by businesses.
Shu, maybe you can comment on the role of PPE in reopening in businesses.
Yeah. It's going to be vital, but I'm not totally convinced that having more PPE is going to solve the problem, in the sense of, I actually sometimes see more PPE as driving more demand, right? In the sense of, if you have availability of masks, then people do more things, which drives more demand, right? And actually is a positive feedback loop. I think, you know, certainly a universal mask policy and having any sort of mask is a good thing, right? I've always thought about it, if people are wearing cloth masks with their favorite logo, that means that they're not wearing the N95 mask that a healthcare worker can be allocated to, right? And that is helpful, and definitely, certainly seems like a decreased transmission, right? And I think we've seen that over and over again. But until, you know, Rajeev and their amazing work with vaccines is going to come, I just feel like we just got to have masks for everybody. But at the same time, it's going to be linked, right? I don't know if we can use an indicator of masks at this point, or supply, to actually be an indicator for opening, because I don't actually think it's a perfect correlation. I think if anything, having more supply will exacerbate kind of quicker reopening and possibly even more infection. So it's a very, very tough link, certainly.
Maybe along those lines, could I ask, you know, one of the concerns, this is one of our PPE questions, if there is a second wave of new infections in the fall, how prepared are we with regard to PPE, ventilators, tests, and beds for all of these different needs, whether it be inside the healthcare institutions or for essential workers in the reopening economy? You know, what's our status of preparation for an event like that? Maybe Shu, you can lead off with this one. Yeah.
You know, again, this pandemic really pushed every one of our limits, right, as a society. I think, you know, the best number I've always thought about was that in the best case estimate, if our national strategic stockpile had functioned, we would have had something like 90 million masks. And we had maybe somewhere from 12 million to maybe 30 million N95s. But some projections put out at 3 billion masks is what we actually needed during this pandemic. And no matter what we would have done, we would have not been prepared, right? What this really pandemic really showed was that there's two models I always think about. It's the just in case and the just in time model. The just in case model being we need to stock up on supplies as much as possible. And the more and more I look at these numbers, the more I realize that just stocking up doesn't actually fix the problem. If anything, it'll be far short. At best, we have 3% of the needed PPE. What I always think about now is that we're shifting to new types of readiness preparedness, and that's just in time, right? Having guidance around what does 3D printing look like as a standard for lots of types of PPE, homemade masks, local suppliers, domestic manufacturers. All those are really important parts of just the just-in-time preparedness that I think we're preparing for. Are we going to be ready if we have a second wave? I don't totally know. We've definitely made a lot of strides. But at the same time, it's going to come from local towns, local communities making that PPE that drives that demand in a second wave. I hope we'll be ready, and there'll be certainly a lot of guidance. So we've improved on that. But certainly, it'll be a challenge to see.
Yeah. Any other comments on that point about the sourcing or the impact of on PPE supplies with regard to the reopening of the economy? And one thing that was also posed by our audience was whether businesses should be expected to add to sourcing for tests or supplies for tests and PPEs, because there's also been this fear that the reopening will lead to more shortage in healthcare institutions, for example, and will ramp up the competition and could potentially also increase prices. So I'm curious, Rajeev, maybe you can start with that question.
We have been very explicit in everything that we're doing that we should not be diverting any supply of anything away from healthcare institutions, frontline workers. So when I probably shouldn't have been using the term masks when I was talking about what we do in the workplace. I should have said face coverings. And we're talking about cloth face coverings that are reusable. So, we've been very, very careful on this point, and we will continue to be. There are places in our environment, such as in GMP manufacturing, where we do have to have certain protective equipment that we order on a routine basis, and that, of course, is continuing. But certainly for the office environment, or in our plasma collection environments, we're encouraging cloth face masks. The same with testing, I would say. One of the key requirements of us even considering a pilot on testing was to ensure that there is far more capacity available than is being utilized, because we never want to be in a position where we are using testing for screening when testing is needed for diagnosis or for tracing and quarantine of contact. So we will continue to monitor that very carefully. My sense of the trajectory is that it's only going to get better, and that certainly for pilot scale activities, we should be okay.
And Ashish, how close are we? Oh, sorry, was there another comment?
I was gonna jump in on that, but why don't you ask your questions? Do you want to ask? Okay, well, let me just.
Well, why don't you jump in and then I'll ask. Go ahead. Thanks.
The 2-second delay in Zoom kills all of us, right? So I just want to build on this idea around workplace and testing, and sort of share what I'm hearing from a lot of business folks that I'm speaking to. And it's a bit complicated, and it's important to try to sort out. There are a couple of issues. So I think a lot of places are thinking about what their testing strategy is, what their workplace testing strategy is. And what I think we're going to see is a real demand for more testing capacity. And there is no doubt in my mind that 3 months from now, we're going to have a lot more testing available, and they will be in many other modes beyond RT-PCR, right? Like, we are going to have antigen tests. We will be using next generation genome sequencing. I'm hoping that the CRISPR-based tests will be available. Will we have millions and millions of them? There's a whole set of issues around ramping up, but testing availability is going to go up. People, businesses that I'm talking to are asking the question that Rajeev has laid out of, how do we both protect our workers but not start taking away from essential testing capacity that states want to do? And here is where we're in a really weird position as a country right now. So if the question is, do we have enough tests? The answer is both yes and absolutely not. So people bring up to me that we have excess capacity, and we do have excess capacity, and yet we don't have enough tests. So how do I square those two things? it's really important to understand that our testing strategy so far has primarily focused on people who are sick, people with symptoms. Now adding in a little bit of testing around contact tracing. But we have never really had a surveillance effort on testing. So we don't do ongoing surveillance of nursing homes. We don't really do ongoing surveillance of high-risk workplaces like meatpacking plants. And because we don't do those things, it feels like we have enough testing capacity. But the moment we start doing those things, which we should have started doing 2 months ago, let's not worry about well, we can discuss why we didn't. But the moment we start doing those things, the problem is going to be that Rajeev is going to start struggling because the state's going to say, we don't have enough tests. And Rajeev is going to want to, I'm just going to pick on him because he used to torture me when I was a resident at UCSF. So I now get a chance to torture him. He did actually, wonderful attending. But the bottom line is, as soon as state sort of increases its demand, it's going to start hitting some supply constraints. I still think this is a really good thing for people like Rajeev's company, Taekda, but others, because right now we're in this very fluid environment where people are investing in tests. I don't think we're using tests very efficiently, and companies that make tests are starting to ask the question: do we need more tests? Are we building supply into a place that is not going to have enough demand? So I think if companies start kind of pulling and asking for more testing capacity, it's going to drive the market in the right direction. So it's a bit of a dance, but overall, I see both the need for the tests and the supply of the tests going up very dramatically over the next 3 months. And I think that those are good things. So I'm looking forward to that. But it's going to be a little bit of, we'll have periods where we feel like we don't have enough tests and other periods where we feel like we have too much testing, and we'll work our way through that. Does that make sense?
Yeah, maybe I can make just add to what Ashish said, because back in the day, I always, as the attending, always used to one-up him or try to. I agree with everything Ashish has said about where we'd like to see testing. I think if we could have screening testing in meatpacking plants and in correctional facilities and prisons, in warehouses, that would be really valuable. While we're waiting for our capacity and availability to get there, there are other approaches that Ashish could talk about at length, I'm sure. The idea of pooling samples so that you economize on the number of tests that you use. And then my favorite thing, which is wastewater sampling, yes. So that you can understand whether, say, in a prison facility, whether you have an outbreak that's bringing, then you can go in and do the targeted individual by individual testing. So there are other emerging ways of doing community-based surveillance that they don't take the place of having robust testing, contact tracing, isolation, and laboratory and the traditional clinical sample surveillance that we need to be doing in communities. But they are potential bridges that should be cost effective and implementable by most communities while they're putting these other capacities in place.
I want to return, thanks for that. I want to return to schools and daycares because I know that is a burning question, and even just play dates and backyard gatherings. So maybe Ashish, you can lead off here. What does that look like? What does a safe school reopening plan look like? What are the most important criteria that should be in place to ensure that they're a safe place to return to?
Yeah, this is I was gonna say $1 million question, probably $1 trillion question if you think about the impact on the economy. If the schools all stay shut down in the fall and winter, it's gonna have huge effects on kids, and it's gonna have huge effects on parents. And as a parent of 3 kids who go to Newton Public Schools, it would not be a good outcome for schools to be shut down for many months. I want to caution folks that opening schools and keeping schools open is going to be very hard. We've seen in many places, Israel is the latest example from this week, where they had done a pretty good job of controlling the virus. They opened up schools and they had really large outbreaks, and they've had to largely shut down their schools. So no one, I think, should see the challenge of opening and keeping our schools open to be something that we can do easily. So the single biggest thing that we can do to ensure that schools can open and stay open is keep the level of community transmission down. If the community transmission levels are high, You can do whatever you want with the schools, all the spacing, all the testing, all the whatever. It's not going to work. So the single biggest thing is we've got to keep community levels of the virus low. Once we do that, then there's a lot of work being done right now to try to gather evidence on what are the right strategies. And there's a National Academy of Medicine project right now, which hopefully will be putting out a report in early July about safe opening that really tries to gather that evidence. But, obviously, I think things like having cafeterias is probably a bad idea. Large gatherings of kids in assembly is probably a bad idea. We have to probably rethink the whole idea of what we're going to do with sports in the fall. So school's not going to look like the way we usually do. I've really thought a lot about the importance of surveillance. So surveillance can come in many forms, whether it's, there's some new studies going on of doing ongoing testing with kids with saliva. That would be, because you're not going to want to do nasopharyngeal swabbing of children on an ongoing basis. I think the wastewater sampling that Rajeev brought up should be a part of that surveillance strategy too. So it's a combination of creating social distancing, getting rid of certain things that we do always that we actually love about schools, but we won't be able to do this fall, and having a really aggressive surveillance and testing strategy in light of a community transmission level that's relatively low. We do all of that. It's going to be hard work, but if we get aggressive, I think we can and should try to open schools. I am worried that lots of school districts that I'm talking to feel like this is an issue they're going to have to start thinking about in August. And the answer is, if you start thinking about this in August or September, you're going to be shut down in October. So that's the basic point, is if you start working on it now, think about ventilation in the buildings, think about airflow, bring in new ventilation things if you need to. There's nothing easy about opening our schools in the fall and keeping it open through the winter. It's doable, but it's very, very hard work.
Yes, and what about a related question, daycare? There were recommendations that just came out this week for Massachusetts daycares that were pretty controversial. And, for example, one of the recommendations was if kids older than the age of 2 are able to, they should wear masks. It seems like a pretty tall order for a 3-year-old to be wearing a mask for the time that they're in daycare. So I'm curious, I don't know, Shu, if you want to talk about, the realistic kind of recommendations for daycare, and then we'll go back to Ashish.
Yeah, I think Ashish's experience is certainly really valuable in this. Mine probably comes mostly from a modeling perspective. So we have, I work with a group called COVID Act Now that does a lot of really impressive work on modeling around just the community transmission spread. And as Ashish mentioned, it's really all down to testing, right? Testing. Because when you have more testing, you know how much transmission there is, and you can be more selective about resource utilization, right? So resources like PPE, as I go back to, or resources like opening and closing, and when you need to close and we can reopen again if there's an outbreak. And short of that kind of mass surveillance testing, we're always consistently trapped in the cycle of, can we open, can we close? We don't know, right? And that is really one of the fundamental questions. What Rajeev brings up in terms of things like kind of the smarter sampling and can you look at waste are really smart. And those to me are kind of new avenues, right? But until we can kind of get that mass surveillance testing that she's mentioned, I think really that's the kind of the key factor. It's going to be really hard to tell. I don't have kids. I don't know. I can't live that experience, right? But certainly, I am certainly looking forward to seeing what happens because I'm not totally sure we have very clear guidance around that.
But Rajeev, maybe I can also get your insight into this because obviously, affordable, available childcare is critical for people to return to the workplace.
Yeah, the problem is we have a data gap on the transmission that's happening at different ages. There seems to be a sense that as you go down in age, that certainly the illnesses, the clinical presentation is less severe. It's quite mild actually, if there at all. But whether that translates to risk of transmission when you get down to the daycare level is an open question. Hopefully there'll be more data to work from by the time we get into the fall. I think it's got to be practically impossible to keep face coverings on a 3-year-old. And let me just say something I've said for a long time, which is that children are very promiscuous with their secretions. And this is a virus that is not just going to be transmitted with kids when they cough on each other. There are going to be quote unquote footprints of children all over any facility. And so I think, I won't say it's futile. I think we need to look at, for example, smaller groups of children with more, pay for more teachers or caregivers in the facility. And so that at least if you have an outbreak in a facility, it's more contained to a smaller number of kids, which means a smaller number of families that are affected. And ideally, you'd have this combined with some surveillance strategy, screening strategy.
Okay. Great. Let me, Ashish, did you want to make any other comments about the daycare setting? Because I think that's been a big
I don't know how to
mark
top
on
these
people's
kids are
minds.
promiscuous with their secretions. So I'm gonna
All right, sounds good. Maybe we can also touch upon vaccines actually at this point before we go to some live questions. And maybe we'll start with you, Rajeev. So there's been obviously a lot of news stories regarding the rapid development of several promising vaccines. So can you just comment on how soon we can expect to see a vaccine available realistically, and how what that vaccine would look like? Are we talking yearly shot? Are we talking permanent immunity? Are we talking, and how effective is that likely to be? Like just analogizing it to, for example, the flu vaccine.
So you've just outlined the content of a 3-hour talk. So let me try to just hit the high points in a couple of minutes so we can get to
for it in
questions.
2 minutes.
So bottom line is that vaccines normally take 10 to 15 years to develop, and the commitments, or not promises, but the aspirations had been 12 to 18 months, and we're now trying to shorten that to less than 12 months. If you look at the U.S. Warp Speed program and an analogous effort that's happening in the rest of the world called the Access to COVID Tools Accelerator. There are 3 big things that can get in the way here of meeting those timelines: safety, efficacy, and manufacturability. And we are absolutely going to be surprised in every one of those areas, guaranteed. We may have an efficacious vaccine, but we'll be surprised that it's not as durable, for example, as we thought it would be. We may be surprised that a vaccine is more reactogenic, causes more immediate inflammatory reactions that are problematic for a vaccine to use in a large number of people. There is this concern of this emerging rare but present illness, inflammatory illness in young children, which is raising questions about whether a vaccine could, once you give it to large numbers of people, could potentially be associated with something like that. There's no evidence that it could, but it's something that we're not going to know for sure until we actually take the vaccine into large populations of individuals. And so there are a lot of things on the safety and efficacy front that could come up to surprise us. And I think that, over 100 vaccine programs have been launched. A handful of them are actually have a pathway to get to phase 3 clinical trials by the end of this year or early next year. Some of those are going to fail. And of the ones that we have left, there is still the challenge of manufacturability, which people, I think, generally don't necessarily appreciate because we don't talk about it much. But a key issue with vaccines is that as you scale up the size of the manufacturing to larger and larger, for example, steel tanks, bioreactors that we use, you have to be able to show that you can produce a product that has exactly the same specifications as it did at the very small scale. And that is not a small undertaking when you're talking about a biological product like this. It's extraordinarily complicated. And this kind of thing, if you get it wrong, can set you back a couple of years. And so I think that the assurances that we'll have meaningful quantities in the US by the end of this year are extremely, extremely aggressive and ambitious. I hope it happens, but I think it's effectively a moonshot, I would say, in this space. The other side of this, of course, is that we all agree that nobody's going to quote unquote cut corners in evaluating safety and efficacy, and that, I believe, is the full commitment that we have from the regulators. A separate issue is how the public perceives the vaccine. So the scientists, the physicians, the companies can say this looks to be safe and effective. The public has to believe that. And I think we need an extraordinary level of transparency in the data that we're providing to justify licensure and approval, so that the public and external unaffiliated scientists can look at that and agree that this is a suitable profile to take into large numbers of people. So my prediction, I would say that middle of next year, I would say we should have meaningful quantities, large quantities of vaccine in the US. That's what I would expect. My hope is that we'll find a mechanism to make the same meaningful quantities available to the rest of the world in approximately the same time frame. Now, is anybody going to get access to a vaccine this calendar year? If anyone, it would be people in the US. But again, that's going to be a long shot. Sue, I think you're on mute.
Sue, we can't hear you. No.
Sorry. Is it likely to be a yearly shot, or is it likely to confer long-term immunity, or is it too soon to say?
Too soon to say. We know that circulating coronaviruses can reinfect you, so that would argue for this potentially requiring booster immunization, whether it's annually or every several years. Tony Fauci believes there's a good chance that this could require repeated immunization. We won't know until we actually do the studies with people that have been, the longitudinal studies after people have been immunized.
And if it is rolled out, if a vaccine were to be rolled out this year with the moonshot, assuming it were successful, would it be, who's it likely to roll out in? And, a related question is, how do we ensure that at any point that the vaccine is distributed equitably so that, again, the vulnerable populations are not left behind in access to a vaccine?
Great question. That's another 3-hour talk. I'll say that the conventional wisdom is that whether in the U.S. or rest of world, that healthcare workers should be at the top of the list for getting any scarce vaccine as it becomes available. Once you've satisfied healthcare worker needs, then you move into high-risk populations and the high-risk groups. How those are stratified or prioritized, that is a topic for the WHO, for the world to look at, and in the U.S. there will be bodies that will look at this and make recommendations. There is a very big effort happening globally right now through the ACT Accelerator to ensure that there are substantial volumes of vaccine available for low and middle income countries in the same time frame as they are made available in rich countries. This has never happened before with a product that is in such demand like this. We've never been in a situation where the entire world has wanted and needed a product at the same time like we're seeing now. So it's really a big experiment, but based on what I've seen so far, I have reason to believe that we'll get a lot closer to equity than we ever have in the past.
I want to return to testing and where we're at. This was the question that I had originally been meaning to ask you, Ashish, which is, where are we in Massachusetts with our contact tracing strategy? And what's the status, and what can we do, if anything, to help try to advocate for more tests to become available? Because it's been a theme through all of our discussion that tests are kind of central to the strategy for reopening and keeping our communities safe and protecting from another surge. So can you speak to the status in Massachusetts specifically, if you're able to?
Yeah, so I mentioned just in passing earlier that we're doing more tests per capita than most states. Rhode Island, I think, is doing more than us. A couple other places doing more than us, but we're pretty good on that front. But we've also had a much larger outbreak. And I believe, given the size of our outbreak, we probably aren't doing enough tests. Now, Governor Baker has laid out a plan for getting to a lot more tests. One of the questions is are we going to be able to do that with RT-PCR? Are we going to really need NGS or some other one of the other technologies I mentioned earlier? We probably will need other technologies. So I've said, and I think it was quoted in a Boston Globe editorial earlier this week, basically saying, we of all states should be setting our ambitions higher. If there's a single state in the country that I can think of that has the kind of intellectual capacity and kind of resources to pull off a fabulous testing infrastructure, it is Massachusetts. I would argue, the kind of the world's home for the life sciences. And so I've really been pushing our governor and our state leaders to think about what does ubiquitous testing look like? It's not 10,000 tests a day. It's a lot more than that. I think it's possible, but we're going to need to continue to see a lot more push from the political leaders, including a financial commitment to paying for all those tests, so that the companies that are going to have to turn around and build business models around this know that they're going to be able to financially survive such a move.
And I think on a related note, Shu, is the availability of PPE. I think, we've all, and our group has been actively involved in this, trying to advocate for national production of PPE. And you mentioned taking a just-in-time approach. But again, what can we do to make sure, because the availability of both of these things, PPE and testing, seems central to reopening and preventing another surge. So is there more that we can do to advocate for national production, given that it's been, a long time coming in terms of action?
Yeah, well, the long time coming is really interesting. The Institute of Medicine put out a report in 2006 that talked about having more research into the design and development of massive respirators that could facilitate reuse, especially emergencies. There was another report in 2008. There was another one in 2019 from National Academy of Sciences. That's something very similar. I think it's kind of going to the same thing, where we all saw this coming, and here we are. But at the same time, things are being solved slowly and surely in context of, one, do we have enough testing? So short of that, the next question is, one, how do we increase supply? Well, we can have standardized testing for 3D printers. We can have all the consumer companies make cloth masks in any capacity. And on the demand side, we can stand up new technologies for reuse, right? UV decontamination has become very popular. It's absolutely the right call, because there is no other way we can get to the demand that we need, right? So I think all of these advocating for just pushing the science is really the right thing to do. And certainly we're the hub of that, right? A lot of these technologies are being tested right here in Massachusetts. And certainly as they roll out here, I do expect the demand will decrease and demand will fall. And so that will certainly help the situation.
Yeah, I think one of the challenges, though, has been this patchwork, I guess, of provision and the approach to supply, as even after we've identified demand. And I think that that's been a struggle. And even I'm curious, too, your thoughts as a panel about the recent, WHO and the CDC. I mean, how are these ever-changing guidance that different national bodies, different states, different governors are putting out? What's the most effective way for us to be unifying so that we can, deliver consistent guidelines, especially for those who are physicians? We'd like to be able to provide the best evidence-based recommendations, and one would hope that those would be consistent. But I think it's been a struggle, and that seems to have impaired our response as well to the pandemic.
I guess you should take that.
Oh, is that for me?
Yes.
Sorry, I missed that. I was like, sounds like a great question. I wonder what Rajeev mentioned. There's a lot, so there are a lot of different parts kind of folded into that question. I mean, one thing I would say is that the science has been changing. So you expect recommendations to be changing, right? Second, there are places where the science is just not very clear, in which case you might expect that it'd be reasonable for a CDC to come out slightly differently than a WHO. That wouldn't be surprising. And we see that in areas where there's a lot of gray. And the third, the real complex part, there are a couple other things here that have gone on that are, so those to me are like normal, natural, what we would expect. What I would not expect, where I think it's been a real problem, is the CDC, which is such a terrific public health agency and in the past has had a lot of freedom to really give science-based guidance, has been constrained in a way that I think is unprecedented. And so a lot of their guidance continues to be excellent, and some of their guidance tends to be kind of head scratching, like where did they come up with that? And that to me has been a real problem. And then the last but not least is what we saw with WHO this week around the whole asymptomatic shenanigans, where, where the person speaking was actually making a very nuanced point, but did it in kind of an inelegant way. And just the whole thing exploded. And for 3 days, I've been like, I and all these other people have been on TV nonstop saying, no, 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 no. Asymptomatic spread is real. It does happen. You do have to wear a mask. We don't have to give up on everything we've learned in the last 5 months. So some of it is just the trick of communication. On one hand, you could argue that it's been remarkable in this pandemic, which none of us had even thought about 6 months ago, didn't exist, how much we have learned, how much we have communicated, how consistent the public health message is. But I think all of us, if there is another pandemic, or even as we move forward on this one, are going to have to think about how to be a bit clearer, a bit more consistent, and a bit more science-based. Because while on one hand you could say it's been pretty good compared to what is possible, it's not been nearly good enough.
Okay. Because we started late, I'm wondering if you have 2 more minutes just to answer a couple of questions from our live Twitter feed. So one question is, how do you see the safe resumption of domestic and international travel playing out? Because many airline and tourism companies are already advertising that they're open for business. Ashish, do you want to take that on?
Sure. So my feeling has been that stuff happens as people get more confident and trust in the system. And so I had assumed, and this is where I'm going to tell you why my predictions are so bad. I had assumed that wasn't going to happen anytime soon, that we would see relatively little travel and tourism throughout the summer. And yet everything I am hearing is that hotels are getting booked for the summer. American Airlines is taking a lot of its planes that it had parked and bringing them back online. And people are expecting a robust tourist season this summer. I have to tell you, I am shocked. That's not what I was thinking was going to happen. So I think travel can be safe. There is some data that planes themselves are pretty safe. Because of the way they filter air. But you know, to get onto a plane, jetways are not safe. They have terrible ventilation. There's a lot of other issues with travel that I think are real. So I think the travel industry has to put a lot of effort into trying to make it a lot safer before people come back. That's the answer I would have given. But the data that I am seeing suggests that a lot of other people are a lot more confident about travel than I would be.
And on a related note, I realized we skipped over one other big question that came up, which is what should doctors be advising their patients about safe communal activities, whether it be play dates, backyard barbecues, that type of thing? What should we be doing now?
Somebody else want to take that?
That's got Ashish written all over it.
I can add in something slightly different, and then but to be honest, Ashish, your advice has been really amazing in this, and I'm going to take a slightly different approach in the sense of communication, right? Going to go back to this idea of how do we communicate finding in a world that's changing every single day, right? Maybe one thing I've seen has been that the traditional model of engagement science has really been one way. And then we will go and go on TV, which is fantastic, and do all these mass communication methods and say, this is the message. With technology, on a digital front, we've really been able to do this much more longitudinally. I think people much expect more kind of the bi-directional discussions. And I think as, as physicians, as scientists, we all have that obligation to be out there. So for example, the Twitter questions are great. But this should be a standard more and more and more so within the culture of medicine to be out and engaging so that people can not only us give those recommendations, right? Specifically for things like, what do you do in the summer? Should we be traveling? Two, when those questions come out, let's get engaged in that conversation, right? I think that is really critical because with how fast a lot of these recommendations are changing, I think it's just a lot of moving the system more towards this acceptability that we're not going to be the effectiveness of just this one-way communication. We've seen that, I think, fail because then, we're so reliant on singular unified messaging in really short compressed timeframes and just moving more towards how can we engage in a constant communication back and forth that I think will allow us to be more transparent, more actionable, more open to people, and also be able to change as recommendations change as well.
Great, thanks for that, Shu. Ashish.
Can I just say one thing about the challenge of communication? So I've been spending a lot of time trying to do communication in the last couple of months. And the point that Shu brought up, so on really subtle, nuanced issues, it's been an incredibly difficult medium, whatever the word is, for communicating. Television is what I'm specifically thinking of. Like, to take protests, the protests that are happening against racial injustice and the pandemic as the context, and how do we think about this and put this together, and what do we recommend as public health people? I've gotten asked that question a dozen times in the last 2-3 days, and I have 30 seconds to answer that. And let me tell you, getting a thoughtful answer on that question in 30 seconds, I've been working on it, I can't do it. And right, because you want to acknowledge what's happening, you want to support what's happening, you don't want to downplay the pandemic, you don't want to downplay racial injustice, and there isn't it's fine for people to protest, do whatever you want, it doesn't matter, nor is it's outrageous for people to protest, you can't do it, there's a pandemic. No, neither of those two answers is right. And so finding a way to be able to engage with people on the subtlety and the nuance and the trade-offs, that's what this disease has brought up for us. It's just a series of really difficult trade-offs. Shutting down the economy for 2 months was not a trivial thing. It's had massive negative effects on people. So all of this is my way of saying any opportunities that we can build in to have those longer conversations, the much more interactive discussions is so much better than the what's the 30-second soundbite on the pandemics and racial injustice in America. Go. I don't know. They're both bad, and we want to fix them. That's my 30
So
seconds.
I want to be, thank you. I want to be respectful of your time, and I know that we've gone a little over time due to my technical difficulties at the start. So I want to close the call and thank you, Ashish, Rajeev, and Shu for taking an hour out of your day today to enlighten us and converse with us. We really appreciate it. I hope I certainly found it really informative. I hope it's informative for all. This is part 1 of a 2-part town hall series that we're holding, and our second session will actually be on structural racism as a public health issue. And I hope that many of you will join us for that conversation as well. So thank you again for your insights today.
Thank you.
Thanks, everyone.
Thank you, everybody.
Bye-bye.